thank you everybody for joining us for our first case report of the semester. We will be doing this every Friday as long as we have students that want to lead a discussion over a journal club or a case report. So again, thanks for joining us. Today we have co-presenters. Student Dr. Theja Bhamidipati and Student Dr. Maren Osterholt. Theja joined KCU after obtaining a bachelor's degree from Washington University in St. Louis, Missouri. He was recently accepted as a student researcher at Indiana University School of Medicine in the Indiana Center for Regenerative Medicine and Engineering School, where he was also awarded a 3-month research fellowship, which he's currently doing. Theja is the first author on 3 papers currently in review, as well as an author along with our co-presenter here on a paper titled Mithramycin-A prevents, oh, I'm sorry, that was the wrong one. Drug-induced bullous pemphigoid masked behind complex medication interaction. And he's also on another one in review, Mithramycin-A prevents early diet-induced insulin resistance in C57 JBL 6NJ mice. Maren, who I mentioned, is also Maren, who is also on the paper Drug-Induced Bullous Pemphigoid Masked Behind Complex Medication Interaction. She joined KCU after getting her bachelor's degree from Miami University. Since joining KCU, she has worked with Score One for Health, providing physical and dental exams to elementary students, helped establish the local Phi Delta Epsilon chapter at KCU, and was recently awarded the Comlex One Excellence Scholarship. If you all could please remember to mute your mics, I will hand this over to them and they will start on the presentation. Thank you guys again for joining us.
Of course, thank you so much. Let me first say it is truly a privilege to be able to speak to faculty and my peers, and Maren and I both express extreme gratitude for having this set up. Once again, my name is Theja. I'll let Maren introduce herself when we go on to the slides, and I first want to introduce the presentation by saying that some of the terms you will see will be left intentionally vague. And the purpose of that is to form a sort of differential in your own mind. So as the presentation goes on, we can sort of act like our own diagnosticians and form our own differential and workup based off how the presentation forms. So without further ado, I'll present Granulomatous dermatitis of unknown origin by Maren Osterholt and myself. Neither I nor Maren have any financial disclosures, and we have no declared conflicts of interest.
So hello, I'm Maren, as Theja mentioned, and we are really appreciative of you guys all being here. So let's go ahead and get started. So as Theja mentioned, today we're going to talk about granulomatous dermatitis. So what exactly does that mean? Let's break it down. So dermatitis is the inflammation of the skin. And then the granulomatous aspect of this condition is the formation of a granuloma. Now what's a granuloma? Well, it's an aggregation of macrophages, epithelioid histiocytes in this specific instance, surrounded by lymphocytes and by giant cells. And they congregate together in states of inflammation, and that can be from a multitude of different conditions that affect the body. So in the bottom right corner, you can see an example of a granuloma. The tiny blue dot cells, those are the lymphocytes, and then you can also see the giant cells within there. Now, it's important to note that there's 2 different types of granulomas. There are caseating granulomas and non-caseating granulomas. A caseating granuloma occurs when there is necrosis or dead cells within the center of the granuloma. And then a non-caseating granuloma occurs when the cells do not die. There's no process of necrosis present, so the cells are living. And in the example I gave you on the bottom right corner, you can see the nuclei, the little dots within the cells, and that represents a non-caseating, meaning living cells granuloma. And macrophages are kind of the whole process, the whole cell that really are part of this process. So macrophage's role in the body is to be a phagocytic cell, and it functions to clean up debris within the body. And then they work together to form these granulomas depending on the state the body is in. So we can go to the next slide. So as I mentioned, there are 2 different types of granuloma, and depending on what condition is afflicting the body determines which granuloma will occur. So for example, caseating granulomas that have the necrosis present, they can be secondary to conditions such as tuberculosis and various fungal infections. And then non-caseating granulomas can be secondary to a foreign body within the body, sarcoidosis, borreliosis, Crohn's disease, and many other conditions that aren't listed here. Go to the next slide, please. So today specifically, we're presenting to you a 59-year-old African-American male who presented with a complaint of sores on his legs. And though we don't have a picture of the patient that we saw, in the bottom right corner is an example of what these lesions looked like when he presented. He first presented July 6th of 2020 to his primary care physician. And as all physicians should do, she started with doing a very thorough history. So what she found out was with past medical history, it was relatively benign. He had chronic constipation, and he was concerned about the possibility he might have diabetes mellitus. And this was because in the previous 2 months, he had lost 35 pounds that was kind of unexplained. He had had excessive thirst and excessive urination. Social history, he was a security guard at a local hospital, though he didn't have too much interaction one-on-one with the patients he worked with, or at the hospital, I should say. His surgical history was non-contributory. His family history was only positive for arthritis on his mom's side of the family. He was taking no medications. He had no known drug allergies or allergies in general. And then on other social history that was relevant, he was a former smoker for longer than a 12-month time span. He admitted to drinking 4 beers per day and occasional marijuana use. And he was married and in a monogamous relationship. So you go to the next slide. So his hospital course, it was very varied and very prolonged. He first presented, like I mentioned, in July, but the answer to what was plaguing him didn't come until towards the end of October. He presented to multiple different hospitals over this course, and he was continuously lost to follow up with the different physicians he saw. So at the time that he presented first in July, he had already been suffering with these sores on his legs for about 1 month time period, and they were extremely painful. And so this was really plaguing his life for quite a few months. And he didn't get as I mentioned, the definitive answer until about end of October. So you can go to the next slide. So to summarize his first visit in July, he had those sores on his legs. He admitted that they were extremely painful. They did not ooze or have any purulent discharge. They were not pruritic or itchy. He said that they would scab over, then they would heal and go away, but they would always return. So he was never without them for a very long time period. As I mentioned, he was concerned for the diabetes with the polydipsia and the polyuria. So to see if maybe he's immunocompromised with this, and maybe this is an opportunistic infection that we're looking at. They got a hepatitis panel to see if that might be involved. They also got a skin punch biopsy of the lesion to see if they can figure out what was involved in this condition. And then they ordered an A1C to rule in or to rule out his concern for diabetes. He was also prescribed triamcinolone, 0.1% topical cream, and bandages for his sores to see if this was just dermatic in nature. And then lastly, they ordered an autoimmune panel to see if this was possibly a reaction his body was having to something himself. Next slide.
So on the next slide, I'll sort of summarize some of the more relevant lab results. I tried to color code it in a way that was a little bit easier to digest. Initially, autoimmune panel was ordered, and that's in blue. That was sort of all the results were non-reactive or negative and within normal limits. Those were sort of ruling out symptoms like lupus, Sjogren's, myositis, dermatomyositis, polymyositis. And in this case, like I mentioned, they were all non-reactive. In terms of the infectious etiologies, HIV, hepatitis B, hepatitis C, and hepatitis A antibodies were also non-reactive. And then in red, we also look at the inflammatory markers. CRP and ESR are these sort of non-specific signs of inflammation and increased sedimentation rate of the blood cells. And the values given here are elevated. They're outside normal limits, but they're not so elevated that an immediate cause for concern was raised. Lastly, in orange, you'll see the white blood cell count, which was slightly decreased. Given the patient's presentation and the chronic nature of this disease, it wasn't unexpected. We did expect some aberrations in his white cell count. So once again, nothing was really raised for immediate concern based off these labs. So as Martin mentioned, he was seen in early July and discharged with the wound care and the lab results. And he followed up with that same physician at the end of July, I believe around July 20th or so. When he came back, he described that the lesions he was having weren't improving with the triamcinolone. In fact, they were worsening. They were previously healing, but this time they weren't healing and they were ulcerating. Repeat lab value of the CRP and ESR showed that the slight elevation that we saw on the previous slide, that was still consistent, and that was maintaining throughout the course of his disease. Of important note, his A1C was actually less than 6.5%, so any concern for diabetes was sort of, curtailed at this point. And just for reference, A1C is the amount of glucose molecules that'll be glycosylated onto hemoglobin molecules, and it's the gold standard for measuring pre-diabetes and diabetic state. Once again, the repeat white blood cell count also showed low leukocytes, which is consistent with his prolonged state and attributed to his new baseline. The concern for vascular pathology, we ordered an ABI, which is the upper limits of normal. So there was no worry of any claudication or any ischemic processes at this time. And lastly, I want to reiterate, just for the broad scheme of things, that there was a negative autoimmune panel for nearly every sort of test we ran. Things like lupus, Sjogren's, dermatopolymyositis, all those were non-reactive. So now the current presentation, which to date would have been around mid-October. The patient continued to have these lower extremity lesions. However, he was unable to follow up consistently as his primary care physician prescribed him to do. He had a very complicated hospital course stay at University Health in Mizzou, where they completed a very similar workup, and they went a step further and ordered a CT abdomen to rule out any sort of abdominal or GI malignancy. The CT at the time showed that there was no malignancy, and they repeated the punch biopsy. And now I'll list the results of the punch biopsy, which is on the screen. The biopsy showed granulomatous dermatitis with perineural involvement, negative acid-fast bacilli stain, negative microorganisms, and scattered giant cells. Now, Martin explained granulomatous dermatitis with the granulomas in the introduction slide, but with a perineural involvement is interesting because now we have a sort of causative mechanism for why this patient is feeling so much pain. The granulomas perhaps are impeding on adjacent neural structures, and that can be causing his pain. He's experiencing a sort of neuropathic pain due to his condition. The negative acid-fast bacilli stain and the negative microorganism stain, combined with the negative HIV and hepatitis panels, sort of ruled out infectious etiologies at this time. However, the persistence of scattered giant cells, these polymorphic cells, was a little bit curious. It's not necessarily a specific finding, but the fact that they're scattered and in a consistent pattern throughout the biopsy site raised concern for a further biopsy. So the assessment and plan at this time was to get even more biopsy results, but instead of a punch biopsy, which is very much a superficial biopsy taken at the epidermal junction of the skin, and very rarely does the punch biopsy extend deep into the dermal structure, we ordered a deep culture, more of the deep fascial layer of the skin, more so than you'd get with a regular outpatient biopsy. More so, instead of an acid-fast bacilli stain, we ordered an atypical mycobacterium stain. This atypical stain looks for organisms more than just what you would experience for tuberculosis. They look for some of the rare diseases. And finally, wound care was consulted, and their management was to continue pain control and follow up outpatient. So now I want to take a second to just take a step back and see a macroscopic view of what's going on. We have this gentleman who presented to a primary care office in early July of 2020, painful lower extremity sores with a concern for diabetes. His follow-up at that same primary office showed that these wounds were not healing, they were not responsive to the steroid cream, and that his A1C was within normal limits, lowering the concern for diabetes. He was told to follow up with wound care and dermatology. However, due to job changes, COVID-19, he was seen at a bunch of different hospitals, with the most recent one seen in Columbia at Mizzou, where he received a negative CT scan for abdominal malignancy. October 2020 is when he presented to the dermatology clinic, and that's what I presented in the previous slide, where the atypical stain and deep culture were ordered, as well as continued wound care and management. So now I'll share with you the final biopsy result of this atypical and deep culture. Heavy growth of Pseudomonas aeruginosa, a positive atypical mycobacterium stain, and an infectious disease management for a consultant. Now, it's interesting here because we were so confident about ruling out an infectious etiology, but now we have a final biopsy result which showed not only one serious infection such as Pseudomonas, but also a second infection of atypical Mycobacterium. And on the next slide, I'll show the final diagnosis, which was confirmed with actually a specialized dermatopathologist, which has actually had to be consulted in specifically for this case. And as I'll show you, the final diagnosis is type 2 erythema nodosum leprosum, as in erythema nodosum, a type 2 hypersensitivity reaction with features of Hansen disease, more commonly known as leprosy. This disease is characterized by numerous eruptions on extensor surfaces, on the bilateral lower extremities. They can even extend to the upper extremities, painful nodules. Usually these nodules do fade to a brawny mark and they heal in relatively cyclical fashions. However, the concomitant infection with Pseudomonas made these ulcers unable to heal, and this structure is able to invade to the deep fascial tissue, making the wounds non-healing, oozing, and extremely painful. A retrospective analysis seems that this diagnosis is consistent with the lab findings, such as the slightly elevated ESR and a low white cell count. More so, since this is an infectious etiology rather than an autoimmune etiology, it makes sense that, you know, the shotgun labs we ordered, where nearly all of the autoimmune titers were actually non-reactive. In particular, I want to point out that Pseudomonas aeruginosa is a relatively dangerous disease. I think most immunocompetent individuals can clear it, but when you're in the setting of repeated hospital stays, repeated clinic visits, when you're in this state of chronic inflammation, what is seemingly a normal infection that can be dealt with becomes very dangerous. You know, it's very resistant to many antibiotics. It ferments in deep fascial tissues in anaerobic conditions, and it can very quickly turn into a life-threatening pneumonia and septicemia.
So now that we have the diagnosis, it's obviously the next step is how are we going to treat this patient? So with this condition, there's about three different steps that you need to take. The first being, due to the immune reaction of the condition the patient's dealing with, you want to give them prednisone or corticosteroid. Typically, physicians will start with 40 to 60 milligrams a day and then taper it down over the time span of about 2 weeks. And the reason to do this is to get the reaction under control very quickly, as well as to prevent any permanent nerve damage the patient may suffer if the immune reaction continues. It's important to note that patients may be on this for well over a year, if not multiple years, if it continues. And it can be recommended, if they're on it for over a year, to switch to everyday dosing, to limit the side effects such as weight gain and easy bruising that they may experience from this drug. And then next, you might be surprised that thalidomide, this is one of the very few indications for this drug. Looking it up, this and multiple myeloma are one of the only 2 indications in the United States we use this drug for. The reason being, in the 1950s and early 1960s, this drug was prescribed for nausea in pregnancy. And it seems like it was this great cure, but then what they started to realize in the 60s is that it was a teratogen, and it was causing horrible birth defects in the children of the mothers that took this drug. So secondary to fear of the drug, public outcry, and just not knowing exactly what it can do to even a non-pregnant patient, it was for the most part pulled from the market. But erythema nodosum leprosum, it's a really helpful drug. And so typically physicians are going to dose the patient with 300 to 400 milligrams daily. And this helps to get the cutaneous manifestations of this condition under control within about 48 hours. And then, similar to the prednisone, you begin to taper it down. So you taper it down to about 100 milligrams, and then you leave it. And every few months, you check back in with the patient and to see if you can, again, taper it down until eventually they're hopefully removed from this medication. But again, it's important to note, if patients need to be on this, they can be for up to several years. If at any one point, though, they start experiencing signs of peripheral neuropathy, that's an indication to discontinue this medication, as that can be permanent. So it's important to teach your patients to look out for numbness or tingling or pain in their fingers and toes, because that can be an early indication of this process beginning. And then lastly, The previous medications I spoke about help with the cutaneous manifestations, but as Theja mentioned, this is secondary to a bacterial infection, so we need to treat that as well. So Dapsone, rifampicin, and clofazimine are prescribed for about 24 months. So it's really important to note that all of these medications they're going to be prescribed for years, and so the patient is really going to need to have guidance as to what this treatment journey is going to look like for them, because it's not a quick fix for them to be healed from it. We can go to the next slide. Thank you. So at the end of this patient encounter, Theja and I discussed what we thought we can learn from it and incorporate into our own careers in the future. So the first being is to recognize the uncommon conditions. In medical school, we learn about leprosy, we learn about a multitude of the zebra diagnoses, meaning the ones you're not typically going to see, and some physicians may never see in their career. But it's important that we learn them because we are going to have patients that suffer from the uncommon conditions. So it helps the patient if you keep these uncommon conditions in the back of your mind on the bottom of your differential diagnosis list, so that if they present, they're not being cured by the standard treatment, or they have an uncommon presentation of something that you think is pretty standard, that you can revert back to this so you can order the extra test to determine exactly what's going on with the patient. And that also speaks to the importance of early interdisciplinary team care. Our primary care physicians are amazing, and they're great at picking up on what this man was dealing with. But as Theja mentioned, a dermatologist was necessary because they have more training with cutaneous manifestation conditions, as well as an infectious disease doctor who has further training on how we're going to cure this. So working as a team with your other physicians that might have further training, recognizing when your knowledge ends and when another's can really help you fill the gaps is extremely important. Medicine is a very team-based effort, and so recognizing that early on is only going to help the patient in the long run, which is the ultimate goal. And then it's also important to recognize that some patients may present to you with a really comprehensive hospital course or a complex hospital course, such as the patient we discussed today. So, as Theja mentioned, he went to Mizzou's hospital and he had the same test ordered up again. And so they had to start from scratch. So speaking to your patient about if they've presented with these same complaints to another physician in the past, and if they have, looking up those hospital records or reaching out to that physician to see if you can get the medical records. Because if he had presented to Mizzou and he said, well, I already had the autoimmune panel done and this and that, then they might have been able to further their own diagnostic studies more quickly, and that would have hopefully helped him come to a solution quickly, which again benefits the patient, both physically, mentally, their health-wise, financially, it's helpful as well. And then lastly, this case highlights the importance of continuation of care. Following up with your patient allows for a faster diagnosis and a more complete treatment. So really reaching out with your patient, encouraging them to come back, and offering them multiple opportunities how to do so. Some patients might not have a vehicle or the opportunity to take off work to get to your office. So if anything, COVID has taught us that telemedicine is a very valuable tool. So if a patient can't come into your office, offering them a telehealth visit might be a good solution to ensure that you can follow up with them and hopefully make it easier on them in their own personal lives and situations.
So now I want to sort of take a retrospective look on what happened on this patient. And I will say it's very easy for Maren and I to sit here and talk about what should have happened, given, the hindsight that we have, and hindsight is 2020. And neither of us were in the position of the physician at the time when the diagnosis was made. So everything I say should be taken with a grain of salt in how we could handle it. So the first issue was that the negative acid fast stain, the negative AFB stain, was treated as an absolute rule out for any sort of mycobacterium species. And this, this isn't the case. There's a lot of atypical bacilli that don't stain on the regular acid fast stain and require an atypical stain in order to be seen. And it's one of those things that Maren said before, we're expected to look out for the zebras, and being aware of that, aware of an atypical stain, could have arrived at this differential earlier and saved the patient a lot of mortality or a lot of morbidity throughout his case. More so, the pain the patient suffered was treated initially as a neuropathic pain because of the worries of perineural involvement from an impeding granuloma. However, the confirmation of a Pseudomonas infection, the deep tissue, sort of changed the paradigm from a neuropathic pain to a more inflammatory traumatic pain. So this patient's pain wasn't being properly managed with things like gabapentin or pregabalin or venlafaxine. And in terms of proper management, we should have been more aggressive with things like NSAIDs, lower dose sustained narcotics, pain management groups. And I think that's one of the things that the patient is going to be most aware of his pain more than anything else. You know, it's one of the things where we probably didn't mention this enough, but there was such disability endured by the patient. Nearly every aspect of his daily life, of his social life, of his professional life was affected by this. And for, 7+ months, 6+ months of him having to endure this, he was getting the wrong type of pain treatment, and that the diagnosis was delayed over that time course. And I think, there's multiple reasons for this. COVID-19 exacerbated the situation, but the burden lies on the physician. On the next slide, I'll mention about social determinants of health. And one of the determinants of health is someone who has a job, such as a security officer in a hospital, doesn't have the job security and might be forced to move between multiple cities multiple times a year. And things like outpatient follow-up with these specialties like infectious disease or dermatology is very difficult to manage. And even if you're able to manage that, it might be months or weeks before you're able to schedule an appointment. And I would say the largest burden of that rests on the physician to account for that and to schedule, frequent follow-ups with referrals across different cities and with the option for telehealth. The last issue I'll speak of, I already spoke about the social determinants, but one other issue was the issue of suspected noncompliance. Like Martin said, there's a lot of drugs needed to treat with this. And in the past, the patient has been lost to follow-up, has had trouble maintaining these appointments. And when you're prescribing medications that need to be taken for months, if not years, noncompliance is a very big issue that could cause even more morbidity in a patient that's already suffered so much. So I think being aware of that in the future practice is integral towards being a proper physician. With that, I'll end with our references and I'll leave time for any questions. Thank you so much.
Thank you guys for your talk. That was wonderful. If we could, this isn't like life size, so it doesn't have that kind of raise your hand option, at least not that I see, for people that do have questions. So yeah, maybe just kind of one of these and I can see you on the screen. So I do see Dr. Johnston and Kelly Joy. Dr. Johnston, if you want to start, and then Dr. Joy, we'll follow up with you if that's okay.
Sure, thank you. First of all, I want to say thank you for this fine presentation for both of you. And Theja or Marin, I'm not going to direct it to either. I'll direct the questions to whoever wants to take it. So the first question is, are there any serological markers that light up with this particular infection or with this particular reaction? Are there any known serological markers? That's number one. And the other one is, you used to see erythema nodosum with some frequency in the lower extremities, more so women than men. Is this erythema nodosum leprosum, is this more relevant to men than women? I don't know the answer. I've never seen a case. So I'll direct the question to whoever feels most comfortable in answering.
So I can speak about the, oh, sorry.
I'll go for it.
So I can speak about the serological markers. The workup wasn't specific for this type 2 erythema nodosum leprosum because I believe the reaction would only show non-specific inflammatory marker elevation, which is what we saw with the ESR and CRP, but because they're so vague, we didn't have a specification for it. And I think definitive diagnosis requires that atypical culture of the actual wound itself.
Yes, and to finish up, as Theja mentioned, I don't know about biological marker, but polymorphic nuclear leukocytes are a hallmark of this condition. So seeing those on your biopsy is an indication. As to your second question, with my reading, I did see that pregnancy and puberty are actually risk.
You cut out. I didn't quite hear that.
Sorry, can you hear me now?
Yes. Pregnancy and what?
So puberty and pregnancy are actually risk factors for this condition, as far as a difference between one way or the other.
I got the one way or the other part, but I didn't hear the high yield answer.
Sorry, my internet might be cutting out. So pregnancy and puberty are risk factors for this condition. As far
Yes.
as non-pregnant in adulthood, it seems to be equal.
Okay.
Okay.
Excellent. Thank you very much. Appreciate it.
I see Dr. Joy, you could go ahead with your question.
So I was going to say first, Shelley, if you click on the participants, it'll pop up on the right-hand side and you can see if we've raised our hands.
I see that. I saw that as soon as I said, I don't know about hands, and then thank you.
So I just want to point out that one of our jobs as physicians is education of the patient. I've seen a lot in different larger medical settings where patients will present and basically the physician group will start at square one. Sometimes that's because they think that, you know, maybe other people don't know as much as they do, or they just don't, you know, it's too much of a pain to get the records and things like that. But I think that the onset of having more access to medical records and really even educating the patient that, hey, we've started a workup, but we're not done with your workup. You know, just because we don't find something doesn't mean we're done trying to help you, is a really important aspect of that. And making sure that the patient has access to their records. So if they go to a different place, that it doesn't start over, because that's just a huge burden on medical resources to start over these $1,000 workups, just like, okay, and we're going to start again and we're going to pretend like nothing ever happened. I would also say that I kind of agree that whenever you first order a tissue biopsy, that you're not necessarily going to order a deep tissue culture and an atypical acid fast stain, because, you know, again, you don't want to necessarily rack up this patient's bills for, you know, something that may be very easily explained. My last point, and I'm sorry, I'm flapping my jaw a lot, but topical pain relief may have been very effective for this patient, like a topical lidocaine or those kind of things, since those are superficial and you're talking about superficial nerves that are involved. So I agree that that there are other things to work with that, but the possibility of narcotics in the case where you can maybe use something topical, it might be useful to head that direction.
Thank you, Dr. Joy. Those were all good points. We appreciate that. I see Dr. Izzard, your hand is up. Go ahead.
Thank you so much, Shelley. Student doctors, thank you so much. That was a very interesting presentation. I really did enjoy it. I had really one question in regards to what you mentioned earlier. I believe you said that that nosocomial infections would it exacerbate the situation, or that was a high risk factor? And if so, given the fact that we're now in the COVID year, and I was looking at the dates that you mentioned when the patient was examined, do you think that because of the extra measures with regards to the environment, of making sure the environment is as free of microorganisms as possible, do you think that had a lot to do with the fact that he did not have a nosocomial infection or leading to something like that? Any thoughts on that?
Yeah, absolutely. I had the privilege to speak with him, and he did mention that with coronavirus, especially back in July in, I think it was in Columbia, Missouri, where they were getting hit rather hard. It was near impossible to go to the hospital for things that weren't emergently life-threatening. And at the time, no one suspected this to be such a deep-seated infection. Combine that with his, multiple settings of his job working in a hospital, obviously a different risk profile than a patient in a hospital, but I believe, that could exacerbate the risk of developing Pseudomonas, which is one of the most common nosocomial immune infections.
Thank you.
Okay, thank you for that. Dr. Wolf, I see your hand is up. Go ahead, please.
Yeah, thanks. Enjoyed your presentation. I was curious if you talked to the guy about whether or not he visited armadillos or anything. I was thinking that armadillos were associated with leprosy, and I was trying to come up in my mind's eye of where this presentation may have come from. I mean, had he been exposed to an armadillo or had something, because Pseudomonas is relatively common. So if you got a lesion it seems to me that he likely had the leprosy first and the Pseudomonas came in afterwards. Is that what you guys are thinking happened too?
Yes, sir. We believe that the prolonged issues with weight loss and inflammatory markers, low white cell count, was the leprosy Hansen-like reaction, and the Pseudomonas was probably an acute exacerbation of his condition, causing him to seek out medical care.
Thanks.
I did not get to ask him about armadillos.
Padfoot mice also, the white padfoot mice also have association with leprosy. Stupid things you remember from medical school.
Thank you guys for that, and thanks for the armadillo and mice. It keeps in mind because they're in this area. Stay away, right? Dr. Johnston, I see your hand is up. Go ahead, sir.
Yeah, I won't monopolize, but there was, I don't know what Harrison still says about Hansen's disease, but when I was a resident, student, etc., I thought at one time it was the hand and leprosy were characterized as the most common site of where hand infections were worldwide was the hand. And now these are lesions on the legs. And my question is simple, did the patient travel to any other exotic places?
So I believe no. I believe in the past few years he was staying within the Midwest United States.
Okay.
I'm not sure if there's endemic regions in the US, but I don't believe he traveled to places like South America or Africa at all.
Yeah. Okay. I just know that, and you guys check me out on it, but Harrison said years ago that leprosy was most commonly, one of the most common causes of hand infestation.
I do know for erythema nodosum leprosum, it's typically seen on the extensor surfaces. So forearms and legs would be common for his specific condition.
Okay.
Is symmetry part of it, or just random? Does the lesion show up symmetrically?
I didn't see any of that in my reading, so I'm not entirely sure.
Okay, thank you.
The patient presentation was, there were so many lesions that it was hard to distinguish a pattern beyond them because they were bilateral and they were ascending, but I didn't notice any sort of distinct symmetry.
Okay, thank you.
Okay. Thank you. I think I had a question that I think based on what Maren said with the treatment, the ointment treatment, I just wanted to clarify. So it's still unknown as far as what how that is affecting people at sort of that cellular level. It's still unknown. It was just very scary and taken off the market and never really researched any further. Or do you guys have any more information on that?
So is thalidomide, is that what you're speaking about? Yes.
Yeah.
So I did look it up, and I was unable to find exactly how it works in pregnancy to help with the nausea. and it has quite a few mechanisms of actions that have been determined. So for example, within erythema nodosum leprosum, this condition has elevated tumor necrosis factor alpha. And thalidomide works by suppressing that tumor factor. So that's how it helps within this specific condition. But in multiple myeloma, it helps because they have increased natural killer cells and interleukin-2 and interferon gamma, and it helps in that way. So the honest answer is there's so many different mechanisms of action that it works depending on what condition it's being used to treat.
No, that helps. Thank you for that. Is there any other questions from anybody? Oh, Dr. Wolf.
I was just going to follow up on that real fast. So the thalidomide thing from a pharmacology perspective is famous for exactly the reason that you said. It was approved, and then they had all the little flippers, and we didn't have nearly as much of that in this country. And so the woman that did it, her name is Frances Oldham Kelsey, and she actually got into graduate school because they thought she was a male. You know, it was Frances for a male, and so she accepted and everything and went. And she then became, so from a pharmacology lineage, I can't remember the famous person she was taught by, but she's actually in my lineage of pharmacologists early on. But she had looked at fruit flies, and she was concerned that she had seen some data very early on suggesting that thalidomide could damage fruit flies. And so she was very reluctant to pass, to rubber stamp that medicine. And it was because she delayed its approval that we didn't have that same degree of problem in this country. So she's highly revered, and she was the first female scientist at the FDA.
Wow. Well, thank you for that additional info there.
Toxicology matters.
Yeah, absolutely.
She helped to create the process that we have now for food and drug. She created a lot of policies. It's boring, but she helped to set the groundwork for having a thorough process.
Wow. Well, thank you. It's nice to hear stories like that. And obviously it impacted the US and, helped save a bunch of babies. I guess the other thought was with the pregnancy and the use in pregnancy, was this something they rubbed on their stomach? So it was, no, I see Dr. Joy shaking her head. No. How does a topical treat anti-nausea? Where were they rubbing it?
I don't believe thalidomide is tropical. You might be thinking of triamcinolone, the tropical cream. They sound similar, but different.
Okay. So it's an oral. Okay. All right. That makes a lot more sense. I was really confused with a topical as an anti-nausea. So thank you for clarifying that. Thank you everybody for the questions and the commentary that followed. It was amazing, and it definitely added to the discussion. Again, thank you student doctors for bringing this to the MKRC and presenting it for us. We appreciate that. If everybody wants to sort of reveal themselves and give them a round of applause, I would appreciate that. And everybody have a nice weekend. This will be posted on YouTube and available on Canvas, and spread the word. Join us next Friday. We'll have another one. Bye, everybody.
Thank you.
Thank you so much.